Mr. Smith, a 58-year-old male with a history of hypertension and hyperlipidemia, presents to the emergency department with severe chest pain radiating to his left arm. The CG shows ST elevation in the anterior leads. What are the critical steps in the management of Mr. Smith's condition according to the American Heart Association guidelines? Answer. In managing Mr. Smith's ST elevation myocardial infarction STEMI, the critical steps include immediate assessment, ABC approach, ensure airway breathing and circulation are stable, obtain confirm ST elevation and identify the leads involved, activate the cardiac catheterization lab. This is vital for early reperfusion therapy, ideally within 90 minutes of first medical contact. Pharmacologic management, antiplatelet therapy, administer aspirin 160-325 mg and consider clopidogrel, 600 mg loading dose, thrombolytics. If percutaneous coronary intervention ECI is not available within the time frame, administer a thrombolytic agent e.g. alteplase unless contraindicated. Anticoagulation. Initiate heparin or another anticoagulant to prevent further clot formation. Supportive care. Monitor vital signs. Administer oxygen if SPO 90% and provide pain relief with nitrates and morphine if needed. Post-management protocols. PCI care should include dual antiplatelet therapy for at least 12 months and lifestyle modification counseling. Relevant guidelines. American Heart Association guidelines for the management of ST elevation myocardial infarction emphasize rapid assessment and intervention to improve outcomes. Describe the stepwise management of a severe asthma exacerbation in the emergency department. What specific pharmacologic therapies should be employed and how do they work? Answer. Management of a severe asthma exacerbation involves the following stepwise approach. Initial assessment. Evaluate the severity based on clinical presentation and peak expiratory flow, PEF readings. Oxygen therapy. Administer supplemental oxygen to maintain SPO 92%. Bronchodilator therapy. Short-acting beta agonists, SUBAs. Administer albuterol 2.5 mg via nebulizer every 20 minutes for up to 3 doses. SAB is work by relaxing bronchial smooth muscle through beta-2 adrenergic receptor agonism. Systemic corticosteroids. Administer prednisone 4060 mg orally or methylprednisolone injected to reduce airway inflammation. Adjunctive therapies. Consider the use of ipratropium bromide, anticholinergic nebulization alongside albuterol for added bronchodilation in severe cases. Monitoring. Reassess after treatment for improvement in respiratory distress and peak flow. Relevant guidelines. National Asthma Education and Prevention Program (NEEP) recommends a stepwise approach to asthma management, emphasizing early treatment of exacerbations to prevent respiratory failure. A 65-year-old female presents to the emergency department with sudden onset of weakness in her right arm and facial droop on the left side. Her husband reports the symptoms started 90 minutes ago. What are the critical steps in management and what imaging studies should be performed? Answer. Management of suspected ischemic stroke involves immediate assessment. Use the FAST method, face, arms, speech, time to quickly assess for stroke signs. Obtain a thorough history including time of symptom onset. Imaging studies. Perform a non-contrast CT scan of the head immediately to rule out hemorrhagic stroke and identify ischemic changes. CT angiography can also be utilized to assess for large vessel occlusion if applicable. Thrombolytic therapy. If the CT shows no contraindications, consider administering tissue plasminogen activator (TPA) within 4.5 hours of symptom onset, depending on eligibility criteria. Supportive care. Monitor vital signs, maintain oxygenation, and consider intravenous fluids if needed. Post-evaluation. Consult neurology for potential admission and further management, including antiplatelet therapy post-thrombolysis. Mr. Thompson, a 72-year-old male with a history of peptic ulcer disease, presents with melena and dizziness. What are the initial management strategies for this patient and what diagnostic tests should be prioritized? Answer. In managing Mr. Thompson's gastrointestinal bleeding, the following steps should be taken. Initial stabilization. Assess airway breathing and circulation. Start intravenous Roman access with large bore cannulas. Initiate fluid resuscitation with crystalloid fluids to maintain hemodynamic stability. Blood transfusion. If hemoglobin is below 7 grams still, or if the patient is symptomatic, consider transfusing packed red blood cells. Diagnostic testing. Perform a thorough physical examination and obtain a complete blood count (CBC). Order a type and cross-match for potential blood products. An urgent esophageal gastroduodenoscopy is essential for both diagnosis and potential therapeutic intervention. Medications. Consider proton pump inhibitors (PPIs) for acid suppression if a bleeding ulcer is suspected. Relevant guidelines. The American College of Gastroenterology Act guidelines outline the management of upper gastrointestinal bleeding, emphasizing rapid assessment and intervention. Mrs. Johnson, a 45-year-old woman with poorly controlled diabetes, presents to the emergency department with confusion and a blood glucose reading of 600 mg/dL. What differential diagnosis should be considered and what immediate management steps should be taken? Answer: in this scenario, the following differential diagnosis should be considered for Mrs. Johnson. Diabetic ketoacidosis (DKA), characterized by hypoglycemia, acidosis, and ketonemia. Hypoglycemic hyperosmolarity (HGS) at high blood glucose levels without significant ketones, more common in type 2 diabetes. Immediate management steps: fluid resuscitation, initiate IV fluid replacement with normal saline to correct dehydration, electrolyte monitoring, monitor serum electrolytes, particularly potassium, and replace as necessary. Insulin therapy. Start a continuous insulin infusion after ensuring the patient has adequate potassium levels. Use a protocol to guide dosage based on blood glucose monitoring. Acidosis management. For DKA, consider bicarbonate therapy of pH 6.9, though this is usually not required. Consultation. Notify endocrinology for further management of the underlying diabetes control. Outline the advanced cardiac life support (ACLS) algorithms for managing ventricular fibrillation (VF) in adults. What key interventions are critical for successful defibrillation? Answer: the ACLS management of VF includes immediate high-quality CPR. Begin chest compressions immediately, ensuring a rate of 100-120 compressions per minute and allowing complete chest recoil. Defibrillation. Apply defibrillator pads and deliver a shock, initially 200 J if biphasic, 360 J for monophasic, as soon as possible. Post-defibrillation management. Continue CPR for 2 minutes after defibrillation, reassessing rhythm and pulse after each cycle. Medications. Administer epinephrine 1 mg every 3-5 minutes after the second shock if there is no return of spontaneous circulation (ROSC). Consider advanced airway management. Once the rhythm is stabilized, consider intubation and ventilation if necessary. Post-cardiac arrest care. Targeted temperature management and monitoring for neurological function should be initiated. Relevant guidelines. The American Heart Association (AHA) guidelines provide the ACLS protocols, stressing the importance of high-quality CPR and rapid defibrillation. A 70-year-old patient with a history of atrial fibrillation presents with palpitations and a rapid heart rate of 150 bpm. Discuss the management strategies, including rate control and anticoagulation considerations. Answer: management of acute atrial fibrillation involves rate control, administer beta blockers, e.g. metoprolol, or calcium channel blockers, e.g. diltiazem, to achieve rate control, targeting a heart equals 2, initiate anticoagulation, e.g. warfarin or a direct oral anticoagulant if the patient is not already on it. Rhythm control considerations. If the patient is symptomatic and the AF has been present for 48 hours, consider electrical cardioversion. Long-term management. Discuss long-term anticoagulation needs and rhythm control options, such as antiarrhythmic medications or catheter ablation. Relevant guidelines. The AHA's guidelines emphasize a comprehensive approach to managing atrial fibrillation, including both immediate and long-term strategies. A 35-year-old male is brought to the emergency department unresponsive with pinpoint pupils and respiratory depression. Describe the initial management and pharmacologic treatment for suspected opioid overdose. Answer: in the case of suspected opioid overdose, the following management steps are crucial. Immediate assessment. Ensure the patient's airway is clear and assess breathing and circulation. Oxygenation. Provide supplemental oxygen and initiate bag mask ventilation if the patient is not breathing adequately. Naloxone administration. Administer naloxone, Narcan, intravenously, intramuscularly, or intranasally. Start with a dose of 0.4 mg to 2 mg, repeating every 2-3 minutes if needed until the patient responds. Monitoring. Continuously monitor vital signs and neurological status as naloxone's effects may wear off before the opioids are eliminated. Supportive care. Be prepared for potential resedation if longer-acting opioids are involved. Relevant guidelines. The CDC and WHO guidelines provide protocols for managing opioid overdose, stressing timely recognition and treatment to prevent morbidity and mortality. A 6-year-old child presents with fever, tachycardia, and lethargy. What are the key components of the initial assessment and management of suspected pediatric sepsis? Answer: in managing suspected pediatric sepsis, the following components are essential. Initial assessment. Perform a rapid assessment using the Pediatric Early Warning Score (PEWS) or similar criteria to determine the severity. Fluid resuscitation. Initiate IV access and administer isotonic fluids G. Normal saline at 20 mg boluses for fluid resuscitation, repeating as necessary based on clinical response. Antibiotic therapy. Administer broad-spectrum IV antibiotics as soon as possible, ideally within 1 hour of recognition of sepsis G. Ceftriaxone with vancomycin. Monitoring. Continuously monitor vital signs, urine output, and clinical status. Obtain laboratory tests, including blood cultures and lactate levels. Supportive care. Provide oxygen therapy as needed and consider vasopressors if hypotension persists despite fluid resuscitation. Relevant guidelines. The Surviving Sepsis Campaign guidelines emphasize rapid identification and treatment of pediatric sepsis to improve outcomes. A trauma patient arrives at the emergency department with a suspected pelvic fracture and exhibits signs of massive hemorrhage. What immediate management strategies should be employed? Answer: in managing a trauma patient with suspected massive hemorrhage, the following steps are crucial. Primary survey. Conduct a rapid primary survey using the ABCDE approach: airway, breathing, circulation, disability, exposure, control external bleeding, apply direct pressure to any visible wounds and consider tourniquets for extremity injuries. Pelvic stabilization. Use a pelvic binder to compress the pelvis, reducing hemorrhage and stabilizing the fracture. Fluid resuscitation. Initiate massive transfusion protocols with balanced resuscitation 1:1:1 ratio of red blood cells, plasma, and platelets. Imaging and surgical consultation. Obtain imaging studies e.g. FAST or CT scan as needed and consult trauma surgery for potential operative intervention. Relevant guidelines. The American College of Surgeons ACTS guidelines outline the management of traumatic hemorrhage, emphasizing early recognition and intervention to minimize morbidity. A 28-year-old female presents to the emergency department with unilateral abdominal pain, amenorrhea, and shoulder pain. After performing a transvaginal ultrasound, you suspect an ectopic pregnancy. What are the key management steps, and what factors influence the decision for surgical intervention? Answer: in the case of suspected ectopic pregnancy, immediate management involves stabilization of the patient, which may include IV fluids and pain management. The main management options include medical management. If the patient is stable, has no signs of rupture, and has G level below the discriminatory zone, typically 1500 mmol methotrexate may be administered. This option is effective in early ectopic pregnancies without significant complications. Surgical intervention. If the patient is unstable, shows signs of rupture, e.g. hypotension, tachycardia, severe pain, or has G level above the discriminatory zone with significant pelvic mass, surgical intervention is warranted. This can be performed via laparoscopy or laparotomy depending on the situation. Factors influencing the decision for surgery include the patient's hemodynamic stability, the size and location of the ectopic tissue, and the presence of significant symptoms such as hemorrhage. The ACOG guidelines recommend close monitoring of G levels and follow-up care. A patient at 32 weeks of gestation presents with painless vaginal bleeding. What are the appropriate steps to manage this condition, and what are the potential complications associated with placenta previa? Answer: in a case of suspected placenta previa, the following steps are essential. Assessment and stabilization. Obtain a full history and perform a physical examination. Assess the degree of bleeding and the patient's hemodynamic status. IV access and fluid resuscitation may be necessary. Avoid digital cervical exams. To prevent further bleeding, refrain from performing a cervical examination. Imaging. A transabdominal ultrasound should be performed to confirm the location of the placenta. If necessary, a transvaginal ultrasound can provide more detail. Delivery planning. The management of placenta previa is largely dependent on the gestational age, degree of bleeding, and fetal status. If bleeding is significant, delivery may need to occur regardless of gestational age. The preferred mode of delivery is cesarean section to avoid maternal and fetal complications. Potential complications of placenta previa include severe maternal hemorrhage, preterm birth, and fetal distress due to compromised blood supply. Adherence to ACOG guidelines on placenta previa management is crucial. What is the definition of postpartum hemorrhage, and what are the first-line management strategies for a patient who is experiencing this condition? Answer: postpartum hemorrhage (PH) is defined as blood loss exceeding 500 ml after a vaginal delivery or 1000 ml following a cesarean section. First-line management strategies include uterine massage. This is performed to stimulate uterine contraction and minimize blood loss. Medications. Administer uterotonics, such as oxytocin, pitocin, which is the first-line medication for preventing and treating PPH. If PPH persists, consider additional uterotonics such as methylogometrine or carbaprost tromethamine depending on contraindications and patient factors. Fluid resuscitation. Initiate IV fluids and consider blood transfusions based on the patient's hemodynamic status. Surgical interventions. If medical management fails and PPH continues, surgical options such as uterine artery embolization or hysterectomy may be necessary. Clinical guidelines recommend monitoring vital signs closely and preparing for possible surgical intervention if bleeding does not respond to medical therapy. Mr. and Mrs. Thompson bring their newborn, who is 24 hours old, to the emergency department. They are concerned because their baby has a yellowish tint to the skin. Upon examination, the infant appears lethargic and you suspect jaundice. What immediate steps should you take to assess and manage this condition? Answer: in the case of suspected neonatal jaundice, the following steps should be taken. Assessment. Obtain a thorough history regarding the onset of jaundice, feeding history, breastfeeding versus formula, and any family history of hemolytic disease. Perform a physical examination to assess the severity of jaundice. Laboratory evaluation. Measure total and direct bilirubin levels. If the total bilirubin is elevated, typically 5 mg/dl, within the first 24 hours of life, further investigation is warranted. Identify potential causes. Consider hemolytic diseases, e.g., Rh or ABO incompatibility, infections, or metabolic disorders as potential underlying causes. Management. If the bilirubin level is significantly elevated, phototherapy should be initiated to lower bilirubin levels. If jaundice is due to hemolysis or other serious causes, further interventions may be required, such as exchange transfusion. Follow-up care is critical to monitor bilirubin levels and ensure appropriate feeding and hydration. A 30-year-old female at 28 weeks gestation presents to the emergency department with contractions and lower abdominal pain. How would you differentiate between true preterm labor and false labor, and what management steps would you take if true labor is diagnosed? Answer: to differentiate between true preterm labor and false labor, consider the following. Contraction pattern. True labor contractions are typically regular, increasing in intensity and frequency, whereas false labor contractions may be irregular and less intense. Cervical examination. Perform a cervical exam to assess for effacement and dilation. True labor is associated with progressive cervical changes. Fetal monitoring. Use electronic fetal monitoring to assess fetal heart rate and patterns that might indicate distress. If true preterm labor is diagnosed, management may include dialysis. Administer medications such as magnesium sulfate, nifedipine, or terbutaline to slow contractions. Corticosteroids. Administer corticosteroids, e.g., betamethasone, to promote fetal lung maturity if the delivery is anticipated within 7 days. Monitoring. Ensure close monitoring of both maternal and fetal status and consider transferring to a facility equipped for neonatal care if delivery is imminent. A pregnant woman at 36 weeks gestation presents with sudden onset abdominal pain and vaginal bleeding. How would you approach the diagnosis and management of this patient, considering the risk factors and potential complications? Answer: the diagnosis of placental abruption involves clinical assessment. Gather a detailed history, noting the onset, nature, and quantity of bleeding. Ask about any previous risk factors, e.g., trauma, hypertension, drug use. Physical examination. Evaluate for uterine tenderness, increased tone, or any signs of fetal distress. Imaging. Ultrasound can help confirm the diagnosis, but clinical judgment based on symptoms and examination findings is crucial. Management strategies for placental abruption include stabilization. Ensure the patient's hemodynamic stability, monitor vital signs, and provide IV fluids as necessary. Delivery planning. If the fetus is compromised or the mother is unstable, prompt delivery is indicated, usually via cesarean section. If the fetus is stable, monitoring may continue with the option for vaginal delivery if the condition allows. Potential complications include maternal hemorrhage, fetal hypoxia, and preterm delivery. Adherence to clinical practice guidelines is critical in the management of placental abruption. In managing a newborn who presents with respiratory distress shortly after birth, what steps should be taken to assess the cause of distress, and what initial interventions should be employed? Answer: in the management of a newborn with respiratory distress, the following steps are crucial. Assessment. Quickly assess the newborn's airway, breathing, and circulation, EACS. Evaluate for signs of respiratory distress, including retractions, nasal flaring, grunting, and cyanosis. Auscultation. Listen to lung sounds to identify wheezing or diminished breath sounds, which may indicate conditions like meconium aspiration or pneumonia. monitoring, continuous pulse oximetry should be initiated to assess oxygen saturation levels. If saturation is 90%, supplemental oxygen should be provided. Initial interventions: if the newborn is apneic or has inadequate respiratory effort, positive pressure ventilation may be required. For mild respiratory distress, consider supplemental oxygen via nasal cannula or CPAP to maintain adequate oxygenation. Further diagnostic workup may include chest X-rays and laboratory tests to identify underlying causes, e.g. infection, congenital anomalies. Neonatal Advanced Life Support (NALS) guidelines emphasize the importance of early recognition and intervention in neonatal respiratory distress. Ms. Martinez brings her 2-day-old infant to the clinic for a routine checkup. She expresses concern that her baby seems to be excessively sleepy and has not been feeding well. Upon examination, you notice that the infant has yellowish skin and eyes. What are the next steps you should take to manage this situation? Answer: in the case of a newborn exhibiting excessive sleepiness, poor feeding, and signs of jaundice, the following steps should be taken. Immediate assessment. Conduct a thorough examination to assess the level of jaundice, e.g. using a transcutaneous bilirubinometer. Note the timing of jaundice onset, which can help differentiate between physiological and pathological jaundice. Laboratory tests. Order a total bilirubin level, assessing both direct and indirect fractions. In the first few days of life, an indirect hyperbilirubinemia is often due to physiological factors or hemolysis. Feeding evaluation. Encourage frequent feeding to promote bilirubin elimination through stool. Evaluate if the infant is breastfeeding effectively or if supplementation is necessary. Management. If bilirubin levels are concerning, typically 12 ml in a 2-day-old, initiate phototherapy to reduce bilirubin levels. Monitor for any signs of dehydration or worsening lethargy, which may necessitate further intervention. During a labor assessment, the fetal heart rate shows variable decelerations. What are the potential causes of fetal distress indicated by variable decelerations, and how should you manage this situation? Answer: variable decelerations in fetal heart rate may indicate umbilical cord compression, often due to oligohydramnios or abnormal fetal positioning. Management steps include: assessment, continuously monitor fetal heart rate patterns. Assess maternal position and change it if necessary to alleviate cord compression, e.g. left lateral position. Fluid management. Administer IV fluids if dehydration is suspected, as this may help improve amniotic fluid levels and alleviate compression. Interventions. If variable decelerations persist despite position changes and fluid management, consider artificial rupture of membranes if membranes are intact to relieve pressure from the cord. Delivery planning. If fetal distress persists or worsens and there are signs of significant compromise, prepare for an expedited delivery, which may involve cesarean section. Understanding ACOG's recommendations on fetal monitoring and management of non-reassuring fetal heart rate patterns is essential to optimize outcomes. A 4-hour-old infant is noted to be lethargic and has a weak cry. Blood glucose testing reveals a level of 30 mg/dL. What are the immediate management steps, and what are the potential long-term consequences of untreated neonatal hypoglycemia? Answer: in the case of neonatal hypoglycemia, immediate management steps include immediate intervention. Administer an oral or IV bolus of dextrose DWW to quickly raise blood glucose levels. The common initial dose is 10% dextrose at 2-4 GIV. Reassessment. After treatment, recheck blood glucose levels to ensure normalization. If blood glucose does not improve, consider further boluses or consult a neonatologist. Identify underlying causes. Evaluate for possible causes of hypoglycemia, e.g. maternal diabetes, premature birth, sepsis, or metabolic disorders, and provide appropriate management based on findings. Feeding. Encourage early feeding to promote glycemic control, emphasizing the importance of breastfeeding or formula feeding. Potential long-term consequences of untreated hypoglycemia include neurological deficits, developmental delays, or seizures. The AAP provides guidelines emphasizing the importance of monitoring and managing hypoglycemia promptly to prevent serious complications. In the context of emergency medicine, how should a physician navigate the ethical dilemma of treating a patient who refuses life-saving treatment due to their cultural beliefs? What frameworks can guide this decision? Answer: physicians must balance ethical principles such as autonomy, beneficence, non-maleficence, and justice when faced with this dilemma. Autonomy emphasizes respecting the patient's right to make decisions about their own care, even if those decisions conflict with medical recommendations. Beneficence involves acting in the patient's best interest, while non-maleficence requires minimizing harm. In such situations, the physician should engage in dialogue, open a conversation to understand the patient's beliefs and values. Effective communication is crucial. Informed consent ensure that the patient is fully informed about the consequences of refusing treatment. The principle of informed consent mandates that patients understand the nature of their condition, the risks of not receiving treatment, and the potential benefits of proposed interventions. Consult ethics guidelines. Refer to institutional ethics committees and guidelines, which can provide frameworks for resolving conflicts in care preferences. Ultimately, if the patient is deemed to have the capacity to refuse treatment, their decision must be respected even if it contradicts the medical team's recommendations. What are the legal implications of failing to obtain informed consent before performing an emergency procedure? Answer: failure to obtain informed consent can expose healthcare providers to legal liability for medical malpractice. Informed consent is a legal and ethical requirement that mandates physicians to disclose the risks, benefits, and alternatives of a procedure, enabling patients to make informed decisions. Key legal principles include capacity. Patients must have the mental capacity to understand the information presented and make a voluntary choice. Emergency doctrine. In emergency situations where a patient is incapacitated and immediate treatment is necessary to prevent serious harm or death, implied consent may apply. However, documentation of the circumstances leading to this decision is critical. Standard of care. Physicians must adhere to the accepted standard of care in their disclosure process. Failure to do so may result in a breach of duty leading to legal action. Understanding these principles helps physicians navigate complex legal landscapes while ensuring patient safety and rights are upheld. Describe strategies emergency physicians can employ to provide culturally competent care to a diverse patient population. Answer: culturally competent care is vital in emergency medicine to address health disparities and improve patient outcomes. Strategies include training and awareness. Physicians should undergo training in cultural competence to understand the diverse backgrounds of patients they serve, including beliefs, values, and health practices. Effective communication. Utilize interpreters when language barriers exist. Employ active listening skills to validate patient concerns and build trust. Tailored care. Adapt treatment plans that respect cultural beliefs. For instance, involving family members in decision-making for certain cultures may enhance care acceptance. Cultural assessments. Conducting a cultural assessment can help identify specific health practices and beliefs that may impact treatment decisions. Community engagement. Collaborate with community organizations to better understand local health needs and cultural contexts. By implementing these strategies, emergency physicians can enhance patient satisfaction and adherence to treatment plans. A scenario where a critically injured patient is unconscious and has no advance directives. What ethical frameworks can assist in making treatment decisions? Answer: in this scenario, several ethical frameworks can guide decision-making. Best interest standard. Decisions should prioritize the patient's best interests, focusing on likely outcomes and quality of life post-treatment. Substituted judgment. If there are family members or known preferences, healthcare providers may attempt to ascertain what the patient would have wanted based on prior conversations or known values. Utilitarianism. This framework evaluates the greatest good for the greatest number, which can be considered in resource allocation during mass casualty incidents, but must be approached carefully in individual cases. Institutional policies. Adherence to institutional policies regarding emergency care and treatment escalation can provide additional guidance. Documenting the decision-making process and reasoning can provide the defense against potential liability if questions arise about the choices made. What techniques can emergency physicians employ to effectively resolve conflicts with patients or their families during critical situations? Answer: effective conflict resolution in emergency medicine can be achieved through active listening. Acknowledge the concerns of the patient or family member. This fosters trust and openness. Empathy. Demonstrate understanding and compassion, which can de-escalate emotional situations. Clear communication. Clearly explain medical conditions, treatment options, and potential outcomes. Use layman's terms to ensure comprehension, involving a mediator. If conflicts escalate, consider involving a neutral party such as a social worker or ethics consultant to mediate discussions. Crisis management protocols. Utilize established protocols for managing difficult conversations, ensuring that all team members are aware of how to approach conflicts uniformly. By employing these techniques, physicians can navigate challenging conversations and improve care delivery. How can emergency physicians critically appraise clinical guidelines to ensure appropriate application in their practice? Answer: critical appraisal involves evaluating the quality, relevance, and applicability of clinical guidelines. Steps include assessing credibility. Examine the sources of the guidelines, including the institutions or organizations that develop them, and check for peer-reviewed publications. Evaluating evidence. Review the studies and evidence base underlying the guidelines. Consider the sample sizes, study designs, and outcomes reported. Understanding context. Determine if the guidelines are applicable to the specific patient population encountered in practice, taking into account local demographics and resources. Monitoring updates. Stay informed about new research and updates to clinical guidelines to ensure current practice aligns with the best available evidence. By engaging in this process, emergency physicians can enhance patient outcomes by applying the most relevant and effective clinical guidelines in their practice. Mr. Thompson, a 65-year-old man with advanced heart failure, arrives at the emergency department in severe distress. His family insists on a do not resuscitate DR order, but no formal documentation exists. The team believes resuscitation could save him. What steps should the emergency team take to resolve this situation? Answer: the emergency team should take the following steps. Clarify the situation. Engage with Mr. Thompson's family to understand their reasoning for the DNR request. This can provide context for their wishes. Assess capacity. Determine if Mr. Thompson has the capacity to make medical decisions. If he is conscious and alert, engage him in the discussion about his preferences. Consult institutional policies. Review hospital policies regarding DNR orders and treatment escalation. Most institutions have protocols for handling such situations. Seek ethics consultation. If a resolution is not reached, consider involving the hospital's ethics committee to mediate and provide guidance on balancing the patient's best interests and family wishes. Document everything. Ensure all discussions, decisions, and the reasoning behind them are documented thoroughly to protect against potential legal implications. Through careful consideration of ethical principles and open communication, the emergency team can navigate this complex situation. Discuss the key components of informed consent and how a physician should assess the patient's capacity to provide it in an emergency setting. Answer: informed consent involves several key components. Disclosure: patients must be informed about the nature of their condition, the proposed treatment, the risks and benefits, and any alternatives. Comprehension: patients must understand the information presented. Physicians should check for understanding by asking questions or requesting the patient to summarize. Voluntariness: consent must be given freely without coercion. Ensure the patient is not under undue pressure from family members or medical staff. To assess a patient's capacity, physicians should evaluate decision-making ability. Assess the patient's ability to understand, appreciate the information, reason about treatment options, and communicate a choice. Consider temporary states. Be aware that conditions such as intoxication, severe pain, or mental health crises may temporarily impair capacity. If capacity is uncertain, it may be appropriate to treat the patient under the emergency doctrine while trying to reach family or legal representatives for further guidance. Analyze the relationship between negligence and malpractice in the context of emergency medicine. What factors must be established for a successful malpractice claim? Answer: malpractice is a subset of negligence specifically applied to healthcare providers. To establish a successful malpractice claim, the following four elements must be proven. Duty of care: the physician had a legal obligation to provide care to the patient. Breach of duty: the physician failed to adhere to the standard of care expected in the medical community, which can be established through expert testimony. Causation: there must be a direct link between the breach of duty and the harm caused to the patient. This is often the most complex element, requiring a clear demonstration that the harm would not have occurred but for the physician's actions or inactions. Damages: the patient suffered actual damages as a result of the breach, which may include physical harm, emotional distress, or economic loss. Emergency physicians must be vigilant in adhering to established standards of care to mitigate the risk of liability. Why is participation in clinical research crucial for emergency physicians, and how can they effectively apply the findings from such research in their daily practice? Answer: participation in clinical research is crucial for several reasons. Advancing knowledge. Research contributes to the collective knowledge base of emergency medicine, leading to improved patient care practices and protocols. Evidence-based practice. Engaging in research helps physicians remain current with evidence-based practices, which can enhance the quality and efficacy of care provided. Quality improvement. Research findings can inform quality improvement initiatives within healthcare settings, driving better outcomes for patients. To effectively apply research findings in daily practice, physicians should stay informed, regularly read medical journals, and attend conferences to stay updated on the latest research and guidelines. Implement changes gradually, apply findings in a stepwise fashion, assessing impacts on patient outcomes and modifying protocols as needed. Encourage feedback, create a culture of feedback among staff to discuss research applications and improve practices collectively.